Good afternoon. I'm Phaedra Cress, Executive Editor of the Aesthetic Surgery Journal, and I'm here with Dr. Peter Lennox, who is the current president of the Canadian Society for Aesthetic Plastic Surgery and the immediate past president of CSPS. Welcome, Dr. Lennox.
Right. Thank you.
So we are talking with you today about breast augmentation and mastopexy, and we're hoping to get some of your insights. It's believed that mastopexy augmentation is one of the most challenging surgical procedures. Could you give us your thoughts on that?
I think that's probably accurate, and I think there's been lots written about it, and people have shown that it has a high revision rate when done as a combined procedure. And I think Scott Spear summed it up. That's when he, to paraphrase him, you're taking the, worst complications of two procedures and then making them additive as opposed to just trying to cancel them out or add them up. So I think that does make it a potentially difficult procedure. Having said that, I think it's one that, has a very high patient satisfaction from, and it's one that patients quite often want as a combined procedure as opposed to a staged procedure.
And how do you feel we've done with the literature that you've read in the Aesthetic Surgery Journal and some of the articles that have come out? Obviously, we try to stay on the cutting edge and publish the latest content, but specifically with regard to fat grafting, how do you feel about what you've read, and how has that helped you to apply techniques in your practice?
I think it's been generally good. I mean, fat grafting is such a rapidly evolving field that it's difficult for, I think, any journal or any publication to stay cutting edge because it's changing all the time. And it's also one that, we're potentially, the basic science is lagging behind a little bit behind the innovation in terms of the techniques. And so I think that's a struggle that we all face. But in terms of both the basic science and the techniques, I've been impressed, and it's certainly one of the journals that I refer to for keeping up in terms of what the potential options are. And I think one of the things that I really appreciate about ASAPs in general is the emphasis on patient safety. So, looking at techniques from a safety perspective, how do we do this as safely as possible? What are the potential risks? So that's one of the things that I found really useful. And, if you look at specifics, sort of the and I don't necessarily do all of these things, but I take parts of all of the different things that I've seen. So if you look at simultaneous, explantation and fat grafting, that concept of replacing potential need for implant with patient autologous fat is one I think that most surgeons are using more and more, and we'll probably see more and more of over time.
So one thing that we talk a lot about, and I'm sure is of concern with your patients, is maintenance of upper pole fullness. How does that factor in?
So I think that, like anything in plastic or aesthetic surgery, really identifying the patient's goals is important. I mean, different upper pole fullness means different things to different people. So for some people, there's no way around an implant once you get a sense of what they really want. But for most women, particularly women who have either had implants in the past or who are looking at a lift, I think fat grafting is a great adjunct. So one of the things I really like is auto-augmentation using lower pole volume in patients that have glandular ptosis. So Frank List has described that really well. Ruth Graff has described it. That concept of using the patient's own tissue to improve the upper pole contour, and then adding fat grafting to that is one that I found really useful in my practice. For those patients that want to maintain upper pole fullness but don't necessarily want that really full upper pole that you can only get with an implant.
Sure, that makes sense, and we appreciate your insights there. So lastly, have concerns about texture affected your choice of implant for mastopexy augmentation? Obviously, BIA ALCL is a hot topic right now. I'm sure it's something that you talk a lot about. Could you give us your insights about texture and what changes you might have made to adapt?
Yeah, it's definitely impacted my practice. So historically, I would have said that if I was going to use an implant above the muscle, I would probably have thought about a textured device just because of the evidence suggesting that there's a lower risk of capsular contracture in that plane with texturization. Now, it's very rare that I use a textured device. I have that conversation with patients, but most of the time, once you have the conversation with BIA ALCL with them, unless I have a really, really strong reason to use a textured device, I rarely use them anymore. Willing to accept a potentially higher risk of capsular contracture to avoid the very rare but described risk of ALCL.
Sure. And you spoke earlier about being grateful about ASAPs and the focus on safety. So in addition to what you just mentioned, how else do you kind of address safety concerns, whether it's about CC or ALCL? What's the conversation like for you?
It's just very honest. I mean, I think, patients appreciate it when we just tell them honestly what we know, what the risks are, procedures, what the current literature shows us, and help them to make decisions based on that. So keeping abreast of the literature in terms of safety and complication profiles of different things that we do is really important. And as I said, patients just really appreciate that honesty, and I don't really find that a difficult conversation. I never had an interaction where going through risks and complications with patients is one that's uncomfortable or they seem like they're frightened. They actually appreciate the information.
Do you think, based on what they're reading in social media, online, etc., I'm sure you get people that come in with printouts and details and kind of horror stories. So how do you handle that? I mean, social media, we're seeing more and more articles about it in ASJ, the pros and the cons. So what's your approach there?
I think that, our job is to try and take them back to reality. So I tell people that, I encourage them to look online at things, but I also, make sure that I explain to them that my perception of what's available online is the whole spectrum from what's, pure science right up to completely speculative nonsense, effectively. And so our job is to sort of portray to them what we know from science and from medicine and from the literature, and they appreciate that. Being able to tell them, reference certain things that show what the risk is, being able to show them articles in ASJ, things like that is really helpful. And then they know that their surgeon is well informed and that their surgeon is thinking about those things and looking at them from a scientific perspective with their with their safety as the focus. And I think that patients actually appreciate that as opposed to getting scared from that.
Sure. I think there's a big reliance and significance on evidence-based medicine. So I appreciate that very much.
There's little changes that we all make to that operation, and sharing that knowledge is really important in terms of different ways of doing it and little tricks that we found to maximize our, the outcome that we can get for patients.
And I think this conversation adds to that. So thank you so much for being with us today. We appreciate it.
Thank you very much. It's nice finding you too.
You too. Thank you.